curiosity ride.
Madbricks webcast,
Where the human spirit flies. Madbricks webcast, where the human spirit flies.
Hey, welcome to the Madbricks webcast. This is Ramana Annamaraju. I'm the host. My last name is a long last name, Annamaraju. I don't ask you to spell it, but long. But anyway, that today was I'm associated with a cardiology. I used to run an imaging center, cardiac center. I used to do a lot of cardiac imaging in old times. Then probably our guest here was not even born, probably. It's like the ultrasound used to be like a small mini truck, almost 400 pounds. So yeah, that's kind of imaging I came from, and she's the state of the art. She does a lot of cardiac imaging. But before that, let me bring my best friend and I let my co-host Susan Davis. Let me bring her to the table. I want to be honest. Before she coming in, I can tell you something. She taught me something. Don't complain. Do the work. I want to complain every day. When then I think about Susan and say, okay, stop complaining. Let us do the work. That's what she motivated me. Welcome to the Madbricks webcast. Poor,
That was
beautiful, brainy woman, and the another one is coming like you.
Well, good evening, Ramana. That was the take home from one of our conversations. I love it. Don't complain. Do the work.
I'll do the work. Yeah, I learned it from you. Thank you. But you're in a very cold place in Cincinnati. You're joining from Cincinnati. You're
Joining
teaching,
from
cardiac.
Cincinnati, yes.
What are you doing there in Cincinnati?
Well, I too am a cardiac lover, as you know, my specialty being, unfortunately, when the heart stops. So resuscitation is my bag, right? The first 2 to 6 minutes of cardiac arrest. So I'm very, very fortunate actually to be in Cincinnati because I'm spending the next couple of days training imaging teams here at Bon Secours Mercy Health in Cincinnati so that their teams are ready to respond if there is a low frequency, high risk event in an imaging area. So we're working with the sonography teams, actually, the Echocardiography sonography teams here in Cincinnati next couple of days. Pretty cool.
You're in a hotel. Sometimes you don't move too much. It's a preview.
Okay.
Yeah, I
Okay.
know. I've been through the hotel by
Okay.
time.
Okay.
It's not good. But at least we are doing fine. But that after that, I'm going to talk about cardiac imaging, and with our upcoming guest, I'm going to introduce you in a second. But I'm going to talk after that. I'm going to present a topic. It is really my favorite topic about science, but not about just science with equations. I'm going to take you a journey into God's landscape. When I use a God in the sense that spiritual, kind of a very strange landscape, I'm going to take you, both of you. This is a purely scientific. I'm not talking about religion. I'm not talking about anything. Something scientific. I'm going to bring you. That's really blowing. When I was finding out that how the science works, really the power of science really inspires me to do all these podcasts. But anyway. So this is your friend, one of your friends is coming on the show. Her name is Dr. Huma Samar. She is joining. Dr. Samar is from my home country, back home, and from Mumbai, India. She is, cardiac imaging. I love cardiac imaging. I told her one time. I spoke with her a few days ago. I told her I am not a doctor. I act one on TV. So it gives me everything about my knowledge of. But I used to have one imaging center running around cardiac. Cardiac imaging is my favorite field. I need to learn a lot more. But let me bring her Dr. Huma Samar. She's from Los Angeles. She's joining. Welcome to the Madbricks webcast, Dr. Samar.
Hi, Susan. Hi, Ramana. Thank you so much for having me here. I've seen a few of your webcasts and really enjoyed them and actually learned a lot. So I'm grateful for the opportunity to be here today. Thank you.
Thank you so much. So tell me a little bit about your journey. Where did you do all this journey up to the Los Angeles Rancho Cucamonga journey?
Yeah, sure. So, like you said, I am from Mumbai originally. I did my medical school in Mumbai, and then I came to upstate New York to SUNY in Syracuse to do my residency and fellowship. And then I stayed on over there as faculty at the VA in Syracuse, New York. And I went on to become the chief of cardiology of the VA over there. And after I had been there for several years, I actually decided to take a sabbatical for a year to do a fellowship in advanced cardiac imaging. Even back then, Ramana, it was very evident that multimodality cardiac imaging was really going to play a very critical role in patient management. And in this realm of non-invasive cardiology, multimodality images would really be needed and would make a big difference. So that prompted me to take that sabbatical for a year to get that extra fellowship training in cardiac CT and cardiac MRI. And after I finished that, I moved to Loma VA as the director of advanced cardiac imaging over there. And that's the position that I still hold. I have faculty appointments in both cardiology and radiology at Loma University, and cardiology faculty at University of California, Riverside.
Beautiful. You have impeccable credentials. I remember, Dr. Samar, when I was doing ultrasounds, let us do ultrasound evolution. There used to be in Seattle, ATL, Advanced Technology Laboratories. I used to buy ultrasound machines. That's like in a truck, 18-wheeler truck used to come down and deliver. It is then when I have a color Doppler, we celebrated. I gave a big party when we had a first color Doppler. It was a huge machine. We had a motor inside to move the machine. So we came a long way. Tell us where your experience with the imaging itself, cardiac imaging, started with ultrasound, or is it mostly cardiologists? I feel that they start with ultrasound, right?
You're absolutely right, Ramana. So the usual training that most fellows will get during a cardiology fellowship is going to be, in terms of non-invasive imaging, is going to be a lot of echocardiography, including TEs, transesophageal echoes. A lot of nuclear medicine is usually built into these 3-year fellowships in almost all programs. So that's where my cardiac imaging journey also started, with echocardiography. And honestly, echocardiography is our workhorse of cardiac imaging. And I think it's going to stay for the near future. Yes, we have very good other advanced imaging modalities, but a modality that you can actually take to the patient, it's hard to replace that with something else that involves multi-million-dollar machines that you have to take the patient to. So something that you can do at the bedside of the patient obviously has immense value. So I don't remember the 18-wheeler truck. That was before my time, I'm very happy to say. But I do remember the era of videotapes, though. That was very much during my time. I do remember the transition of echocardiography going from our videotape archives to the digital archives that we have now. And but yes, when I did my fellowship, all of the modalities that you spoke about, color Doppler and all of those things were very much there. But 3D echo came after that time. 3D echo is something I sort of learned on the job, so to speak, and wasn't part of the fellowship training. So I got my echocardiography and nuclear medicine training during my 3-year
Let us stay in one.
core
Stay on, Dr. Samar. Let me ask you. Stay a little bit on the ultrasound. What kind of diseases you can diagnose? Well, it is evolution. Evolution. You're talking about from big 18-wheeler to now with the iPhone. Complete evolution and the diagnosis and treatment. Diagnosis, at least. That what do you do with this present day technology? What else you can do? What are the more things you are doing from last 10 years or so with the ultrasound?
Yeah, echocardiography has expanded over the years tremendously. When I started off, it was more very subjective imaging. We were not doing so much in the way of quantification. Even when it came to simple things like ejection fraction, or more complicated things like valvular heart disease, quantifying regurgitant valves like mitral regurgitation, quantifying aortic regurgitation. All of those things were being done more subjectively, just visual assessments. Whereas now it is pretty much standard of care to quantify any of the valvular lesions that you see on echocardiography. So when it comes to valvular heart disease, echo is the gold standard for assessing valvular heart disease.
Before I hand over to Susan, one more thing I wanted to ask you. So it is a diseases, and also the machine equipment evolution is now we have a focused ultrasound, right? Portable ultrasounds that are coming in. It is you can do that in the this is kind of a change the landscape of the ultrasound business, because that's the eyes of a cardiologist, right? Tell us a little about focus, and then I will hand over to Susan. Beautiful
Yeah,
Susan, they're waiting.
You're absolutely right,
Yeah.
Rama. Focus is pretty much standard of care now. In our ERs, in our ICUs, in all of these inpatient settings, it's very normal to have, the attendings, the residents, the fellows, all moving around with focus probes to, whenever there's a clinical question, put the probe on the patient's chest, try to get the images that you can to answer the question, rather than waiting for a full-fledged sonographer done echocardiogram. So that is, you're absolutely right, that is definitely standard of care. And focus has also moved into the outpatient setting. When I was looking at a few studies, I was very surprised to see that in one study, it was reported that up to 44% of family practices said that they use focus in some form of or another. Wasn't all cardiac, they use it for other reasons as well, but cardiac focus plays an important role. And when you spoke about innovations, there is, of course, a lot happening in the field of AI and echo, but one field or one part of this that I'm following very closely because I'm very interested in it is these AI embedded focus probes, which can actually guide a novice person to take basic echo pictures. I mean, we're not talking, 50 images and 60 measurements that a sonographer does, but a very basic echo, 2 views, 3 views, that can give you a simple ejection fraction with very good accuracy. So it's not just residents and fellows or physicians who can do these focus images. It's nurses. It could be any staff in a clinic, because it actually guides them step by step where to place the probe, how to angulate the probe. There are cartoons on the screen telling them that angulate downwards, clock the probe, anti-clock the probe. And the moment they get a diagnostic quality image on their screen, it automatically captures the image, and then the AI runs in the background and does the ejection fraction calculation. And you think about that, that's like really taking focus to new heights. You think about what we could do with that. We know that our heart failure patients, almost half of them present to primary care first. The other half, unfortunately, show up in the emergency room or in urgent care. But when they have symptoms, they don't come to see a cardiologist first. They go to their primary care physician. And very honestly, Ramana, making a diagnosis of heart failure is not one of the simplest things.
Great point.
Yes, the symptoms can be very vague. People can say they're fatigued, which, and you think about fatigue, the differential diagnosis is pages long. Heart failure is one of them. And the signs can be very subtle. So sometimes even the most seasoned cardiologists will struggle with making that definitive diagnosis of heart failure. So having that echo available right at that point of care can really make a difference. You have that quick 10-minute echo that your medical assistant or your nurse can do, and that tells you this patient's ejection fraction is 30%. You start therapy right there before waiting that 3-4 weeks before the patient gets a full-blown echo or gets in to see his cardiologist. You start medical therapy at the point of care and hopefully prevent that patient from deteriorating, from ending up in the emergency room.
Beautiful.
So it's just showing how clinically meaningful that information is, and at the point of care, whether you're rural or at a clinic, that's amazing. I mean, hot off the press, Dr. Samar, October 2022, just a month or so ago, the American Heart Association put out their Q5-year recommendations, and I was wondered to see that they did have a recommendation for point of care ultrasound post cardiac arrest. my background as a trauma nurse, we would use fast exams, in the trauma room for obvious reasons. Same thing. It's very clinically meaningful. You might not see the whole picture, but we might be able to see something that would help change our direction quite quickly. So what did you think about the American Heart putting on paper that it was something that they recommended? It could possibly be very meaningful to use point of care ultrasound post cardiac arrest.
Absolutely.
Good question.
In cardiac arrest, it happens in a hospital setting. That is, again, a given. We do it on any cardiac arrest that happens in the hospital. Because again, at a cardiac arrest that happens in a hospital, there's so much staff around. You always have physicians around and so on. So it's very easy to do. But I think this will now take that point of care ultrasound to even our EMTs potentially, to a lot of different places where this can be available and can actually make a difference, where you truly would change what you would do. Like you said, does this patient need to be rushed to the cath lab, or is this a huge pericardial effusion? Is this a blown out RV, and does the patient have a PE? There's so much that you can tell so quickly from that focus ultrasound.
Yeah, very exciting times.
Absolutely.
Yeah, go ahead. Anything?
Go ahead, Romana. You're hogging this evening.
No. Let us talk about other imaging. But the first and second one is the prevention part, right? In the cardiac prevention, cardiac CT. Every doctor talk about calcium scoring is the gold standard for the cardiac screening. For the prevention. So, what is your calcium scoring things? You can shed some light on it, and what are the modalities you use it in general? If you can, that would be very useful for not only for me, for everybody, for entire world, and the doctors also.
Yeah, absolutely. So calcium scoring is a very simple CT scan. It's a non-contrast scan. You don't need an IV. You don't need contrast. You don't need any pre-medications. It's a very quick scan that gives us an idea of how much calcified plaque is in the coronary arteries of any patient. So that's basically what a calcium score does. Now, who is it recommended for? So guidelines recommend that if any patient is at an intermediate risk for coronary events, and where does this intermediate risk come from? We use these ACC-AHA calculators when we see patients in clinic to determine what their risk of a future coronary event is. And when you use those calculators, if you find patients in that intermediate risk zone, they're not really, they're not low risk, but they're not super high risk as well. They're somewhere in the middle. That is where guidelines recommend that you should do a coronary calcium score, because it will give you added information over and above what that risk score has given you to help you guide preventative therapy for that patient. And to be perfectly honest, Ramana, our these risk calculators that we use do have some drawbacks. They don't take into account very important things like family history, obesity, waist circumference. These things don't feature in our calculators. So they do tend to systematically underestimate risk. So yes, a calcium score is definitely a very good test as a screening test to determine if what is your patient's risk of coronary disease is. But when we're talking about using calcium score, I think we should at the same time also talk about when we should not use calcium score, because we do see it used in situations where it's not going to help. So if you have patients who've already had coronary artery disease, who've had either an MI or a previous stent or bypass, there is no utility to doing a coronary calcium score. They are already in the highest risk bracket. There is no additional information that a coronary calcium score is going to add. The second type of patient that you should not do it for is somebody who has symptoms. This is a screening test, a coronary calcium score. Like you said, a test that will help you in prevention and hopefully preventing that first event. But if somebody has symptoms, even if they're mild, even if they're non-specific, a calcium score is not a test for a symptomatic patient. It's a screening test for an asymptomatic patient to better risk stratify them.
Dr. Samar, sorry.
No, go ahead, Susan.
I recently heard of calcium scoring. There's a new AI. We're doing calcium scoring from chest CTs, so they're kind of like an incidentary finding. Have you heard of that?
That is actually very exciting. That is generating a lot of excitement in the cardiology community, in the preventative cardiology community as well. And we describe this as opportunistic screening. And this term has gained a lot of popularity in the last 2 years since they first coined it at RSNA, a couple of years ago. And what that basically means is that you're going to get the information that you would otherwise get from a dedicated Cori calcium score, from a CT scan that was done for any other reason, a CT of the chest. It's not a dedicated CT of the heart, it's a CT of the chest, for a pneumonia, for lung cancer screening, for detection of a P, for n number of reasons that a CT scan of the chest is done. You can get information about a Cori calcium score. Now, to be perfectly honest, Susan, this is not entirely new information. We've known this for as long as we've known how to look at CTs, that we can see Cori calcium on the CTs. Going back to 2016, our guidelines recommended that whenever any regular CT scan is reported, there should be some mention of what is the extent of Cori disease. We didn't have AI Cori calcium scoring on CT scans back then, but we had radiologists saying, it's mild, moderate, or severe just by looking at it. And studies have shown that even that mild, moderate, severe correlated very well with calcium scores that were done on dedicated, Cori calcium scans. Yeah.
Wow.
But even that did not gain widespread adoption at all. It's so sporadic. Some centers report it, some centers don't report it. In one center, you'll have some radiologists report it, some don't report it. When clinicians see this coming back, they're not sure, what do I do with this information? I had not really asked for this information. What do I do next? So that never really took off. But what you're talking about, the AI calcium scoring, is really very promising, because one is, it's something that sort of runs in the background on any CT scan and will generate this calcium score. And the calcium score is something that primary care physicians are very familiar with. Our calcium score is a very well-validated tool with very well-validated cutoffs. Every primary care physician knows that if a calcium score is 0, I can withhold statins unless the patient has diabetes or is a smoker or has family history. They all know that if the calcium score is between 1 and 100, statins are favored, especially if the patient is over age 55. And if the calcium score is over 100, yes, absolutely, statins are needed. Something that's very well validated, very well known widely. And now with the help of this AI CAC, that is something that information can come onto any CT scan report fairly easily. So it's definitely very exciting. We can screen patients at a population level now. We do 1 million Cori calcium scores. We do 19 million CT scans for lung cancer screening. So now we can open up Cori screening to a much wider population.
Let me follow up Susan's question a little bit about that. The coronary, when you take a calcium scoring with the CT, you're getting the state of at that time, state of the disease, right? You don't know how fastly progressing. So AI can help you to say how fast it is going to progress. Is that right? Or is that one of them? Am I right?
Super resolution, right? Faster and super resolution. These are the AI words?
No, so Susan, what you're talking about now is you're coming into the realm of coronary CTA. So a calcium score is a one-time screening test. Okay, you do that test to determine what's your patient's risk of disease, and based on that, you start, your preventative therapy. There is really no role to repeat a calcium score every year or every 5 years or 10 years, unless your patient starts off with a 0 calcium score and you decide that I'm going to withhold statin therapy because this patient is very low risk. So in that patient, you can repeat a calcium score at 5 years or 7 years and see, has there been a change and do I need to start therapy now? But when you have an abnormal calcium score, there is no utility to repeat that to either accelerate or decelerate your therapy. Then what you're talking about, what you need is a coronary CTA, which can look at not just a calcium score or not just calcified plaque, yes, but can also look at non-calcified plaque, what's described as soft plaque, which is the lipid-rich plaque, which is the precursor of your calcified plaque. So what happens is initial plaque deposition with lipid deposition and then inflammatory cells usually has a thin fibrous cap and is more prone to rupture. And as that plaque stabilizes, as we treat patients with statins and all these lipid-lowering therapies, and the amount of lipids in that plaque decreases and the plaque stabilizes, it calcifies. And when you have the calcified plaque, that is what you pick up on your coronary calcium score. But you don't see the lipid-rich plaque. You don't see the plaque that can actually rupture and cause an acute coronary syndrome on a calcium score. For that, you need a coronary CTA.
So still, I'm not. My question is how aggressively spreading this calcium scoring, calcium plaque. We don't have any measurement of how aggressively blocking the coronary. Or is there any analytics can do that? AI analytics can tell you that, and a preventive way. Hey, this particular person, the progression looks like the mathematics is telling you the progression is going to be very aggressive with this person. Is there any something like that there available, Dr.
Yes.
Samar?
Yes, and that's not, again, in the realm of the calcified plaque. That's more in the realm of the non-calcified plaque. Because when you treat patients with statins or with lipid-lowering therapies, what we can decrease is the non-calcified plaque. Once the plaque has calcified, it's not going to change much. It's not, yeah. So you can really make a difference is when you have the non-calcified plaque. And to your question, Ramana, yes. So now we have, with coronary CTA, we have the ability to do plaque quantification. So we can quantify, we can actually have a number as to what is the volume of plaque in every coronary artery and how much of that volume is calcified plaque, which is stable, and how much of that volume is non-calcified plaque, which with our lipid-lowering therapies, we can actually make a difference and cause that plaque to regress. Yes, we can actually, by looking at a coronary CTA now and by quantifying the plaque that is in there, we can tell that which patients, if we treat them aggressively with preventative therapies, we will be actually able to decrease their plaque burden and subsequently decrease their risk of future events.
The biggest challenge, Susan, just give me 1 second. I'm going to ask you.
That's okay.
The biggest challenge is that the CT is not available in rural areas or in countries like back home, like India or any other. Lot of countries don't have that access to CT. Are there any advances coming up to measure indirectly calcium scoring?
So yes. So, one of the things is, like we mentioned, the AI opportunistic CAC. We're looking at CT scans. The next, sort of taking this opportunistic CAC one step further, is determining calcium scores from chest X-rays, from a simple chest X-ray, which is ubiquitous. It's everywhere. It's not just rural, it's in all developing countries. It's very easily available. So there are AI algorithms that are looking to get us calcium scores from chest X-rays, but there's also now a special kind of X-ray machine. It's not remarkably different. The difference is that it has dual energy X-rays rather than single energy X-rays. So because it has dual energy X-rays, it can do a bone subtraction, and it can also do a soft tissue subtraction. So it can actually calcium score on a simple X-ray. And that is something that is being studied as well. So yes, we may come to a point where we can do this coronary calcium screening from something as simple as a chest X-ray. We're not there yet, but we may be getting there. The other thing is mammograms. We do mammograms for all our female patients every year after age 40. They're also looking at what's called breast arterial calcification, something that is seen in every mammogram. You can see if there is calcification in the arteries of the breast and trying to correlate that with the risk of coronary disease.
Oh my gosh, that's so amazing.
Yeah.
Absolutely.
So a twofer, right? So these are all these opportunities. The point of care ultrasound. We're already there for CT. Chest X-ray, and now mammogram. We're there for mammogram. So there's 1, 2, 3 different ways that we can really bring care to the people in this highly innovative, entrepreneurial, crazed world. We still have to be of service to the people. And so with this amazing, I love these 3 examples of how to bring that amazing type of service to the people, making it accessible. Huma, that's exciting.
Yeah, it is. It certainly is. And it really opens up the possibilities of being able to screen for coronary disease at a population level.
Yeah.
Being able to do this on a really wide scale. I think you're absolutely right. I think the future is very exciting.
Very
Let me-
exciting.
Yeah, absolutely. Great, great, great. I didn't know that mammogram, you take all the mammograms and can extract that the data for the heart disease. Amazing. Let me ask you, I heard Dr. Nathan Wong was one of my, I interviewed him on my podcast. One of the things he was saying, LP little a is some kind of a protein testing, can tell you the risk of the, poor man's cardiac calcium scoring, probably that is. So it can tell you much easier. Tell me what is the role of the LP, a genetic testing does that?
Yeah, I think LP little a definitely is a very powerful marker of the risk of coronary disease. We don't test for it enough. That's very evident. And I think slowly but surely it's the awareness for LP little a screening is increasing. And it really has the ability to change how we, again, risk classify our patients. Because you may have a patient that may have perfect looking LDL cholesterol, and you may feel that this patient does not need a statin or does not need any other further drugs that would help decrease their risk, or lifestyle modifications for that matter that would decrease their risk. But when you check an LP little a and it is super high, that completely changes how you think about that patient and how you treat that patient. So it definitely is a very, very useful additive test that we don't do enough of, unfortunately.
Dr. Huma, I was going to switch. Is it time for you to do your presentation, Romana?
Yeah, in a minute. Just
Okay.
I wanted to ask you when you come back after the presentation, you just go and ask questions. One of the questions I want to ask you about the nuclear thallium. It's a huge machine. I used to sell that actually. Then PET CT scan. These 2 modalities. Let us talk about that, the role, and are there any solutions for this huge, massively capital intensive equipment? So we're going to talk about that when I get back to you. A little bit of shed light on those 2 other imaging modalities, which is the nuclear thallium, and then the other one is that I was recently micro bubbles. Susan talks about all the times micro bubbles studies. Then PET CT scan and a little bit of the contrast they use. But I'm going to when I get back, I'm going to present a topic on very interesting. You're going to I want you to. It's kind of related to cardiology, but it's not exactly cardiology. I don't know where is my. Yeah, let me see that. Yeah, she didn't. Let me bring that this sheet. Yeah, very short presentation. That is a Dr. Huma Samar, where that's very short. I got another question I'm going to ask her about the Indian catastrophe as Indians, how much we need to watch about the cardiac diseases. That's Dr. Huma Samar joining from Los Angeles. She's a cardiac imaging expert. Really good. I'm going to present a topic on something interesting. Maybe, I hope so. Not measuring it. There is a new technology coming. She's just Dr. Samar is talking about a new technology. Is a focus ultrasound, for example. But there is something fantastic going on in somewhere else. I will tell you about that. We use everybody right now. We are all in the computers. We are all using computers, keyboards, and mouses, right? This last 20 years, how much ground plastics we accumulated in the dumping ground. 2 million keyboards are there right now. 4 million mouses under the ground right now. No, I want to change that point. It is not under the ground. Do you think where it is? in your body, in our bodies. That's it. They seep into the water, they seep into the air, they seep in the microplastics slowly lengthen. One of the main things for Susan and Dr. Samar to worry about is a cardiac disease. That is a proven peer-reviewed study from the seeping of these plastics, microplastics, can cause the number one disease, the cardiac disease, or coronary heart disease. The JAMA published actually March 29, in Journal of American Medical Association journal, very prestigious journal, published in March 29, 2024, last year. So the lungs affected, the placenta of the babies in the future, these are the health hazards for the pilot. So there is something we need to do, we can do about that. I'm going to talk, this is a magic, I'm going to do a magic wand and disappear all the keyboards and mouses same time. I tell you how I do that. Susan may believe that, but it's not.
I do. I believe you.
You believe that. Yeah. This is called no magic wand, actually, Susan. Sorry to disappoint you. But this is called surface electromyography. It is a very new, very strange. The use of it's like a watch, like a Fitbit. It's not a Fitbit. This is a very strange kind of a technology. The surface electromyography measures the electricity in the body. That's what it is. It measures but electricity is life. So this is going to change the entire world. I'm going to tell you, revolutionize the world. So how do you type it? How do you type something on the computer? Let me tell you what the process does in the brain. I'm going to tell you a landscape of the brain and mind and very strange world I'm going to take you. A thought is created in the brain. I want to press a T. A thought was created because there's a fractal geometry. The thought was all the neurons assemble in a certain way and say, press T. Okay. I don't know what happened. Yeah. So sometimes Susan disappears, with the magic wand. So that brain thinks about the T first, then thinks about a thought is formed. Then it sends a nerve signal. Immediately, the nerve signal sent it to the neuromuscular junction into the finger, into the wrist actually. A signal is sent to the wrist. Then in the wrist, there is a muscle. The muscles create electricity. That electricity moves the finger and we press T. That is a traditional process, what it does. The science behind present day, how you type the in keyboard interaction or mouse interaction. So my physics came up with a brilliant idea. What about, I'm going to follow all the thought is created. You want to press T, neuromuscular junction, you got the electricity there. If I put a detector there, without moving the finger, can I find out what I'm thinking? That was a strangest thing. It blew my mind. It is an intentional reader. What it does is this wristband can read the fibers inside, the electrical patterns inside. Before I type anything, scroll, type, press any buttons, it knows this device knows what you want to do. It figures your intentions. Very strange. That tells you want to press T, that is the electrical pattern. It matches a particular pattern than microfibers inside. There is out of 20,000 fibers, 5,000 motor nerves says that you got to press T. It doesn't say that. It doesn't know there's only electricity. But the pattern is recognized by this machine. That's the wristband. The wristband, The wristband, how it works. So the electric signal goes to my finger, my index finger. That it has a very clear patterns what that is. That pattern says I need to move my finger, your index finger. That is the signal, electrical signal came. You see, out of all the 5 fingers, the red one is on on the electrical signal on the index finger. So that means my intention, at this time I'm not moving anything. My intention was read by the wristband. The moment it reaches the intention, there is a software. It comes in the picture. It tells you what is your gesture is. It's not a gesture that you're thinking, not with the hand moving. You don't move anything. It's a mind gesture. You're thinking of moving to your finger, index finger to press T. Little complex. Need to understand. So every letter has a pattern. That's what it reads. Not only I want to move the finger, and the T, there is a letter next to the T is R, but it doesn't press R because it recognizes the pattern in that index finger and goes to the T. It knows it is a T you're trying to press. UX interface does that. So what is so special about that? You can get rid of all the keyboards, all the mouses, once and for all, gone. You don't need a keyboard. You're thinking, it goes writing on the monitor. So there is no keyboard. Whatever you think, because it is electrical signal, it is recognizing, this pattern recognizing and writing what you wanted to say. Isn't it? That's a very intentional reading, a mind reading, in fact. It is an amazing science is being developed. So there are a lot of companies opened up right now. One of the companies is called Mudra. They sell it right now. It's called a Mudra wristband. You can buy for $350. If you want to be cheap like me, you can make your own for $50 in the Fly Electronics. So surface electromyography wristbands, Apple is doing it right now. MyoWare, Shimmer, a lot of companies jumped in. This is a huge opportunity for them. This changes the landscape of the computer industry and the whole hardware industry. So what is direct savings of this? $32 billion for 3 years. Even if you buy for $50 or $70 for the wristband, the amount of money that you're spending on keyboards and mouses, they're all mechanical, they go bad, they go into the dumping grounds. You can save $32 billion in 3 years. You know what? We can save that money we take and can save lives. United States have only less than 3 million AEDs, automatic defibrillators. Susan and Dr. Samar does. Now, 30 million AEDs requirement is actually USA requirement. It is by Garden Studies. Studies that 30 million AEDs required across the country. We are nowhere closer to that. So Susan is an expert in this area. She goes to the rural areas and train all these people. But you know what? That you can bring you can put every city, America first. You can put in every village these AEDs without saving money, with that wristband. And this wristband does a lot more than those. It is a fall prevention. It can give you 1 second advance notice before you fall. A breaker, anything is breaking, falling. 1 second is it's a huge amount, because I was surprised. Most of the human reflexes are 200 milliseconds. Our reflexes are much faster than a computer reflex. So if you give a 1 second prevention, 1 second advance notice, you can do a lot of things. It calls the caretaker, it calls everything, and it alerts everybody in the family, and then can come up with the cushion, maybe airbag, inflate, all those things can do. You know what the cost of the fall prevention? $50 billion at this time, every year. You can save one person, 50 is a $500 million. Susan can give them AEDs for entire India. So, a lot of people, I'm in Silicon Valley, a lot of these people walking around, Indians, Dr. Samar may know a lot of them, because they walk with the diabetes. We don't know. They don't know. They walk with the diabetes. They don't even know. because we are the high risk group. So what he does is, nobody wants to go to, particularly guys, never want to go to the doctor, never care about it. 25-year-old, no, I don't care. But because they see the world different. But they never stop going to the computer. When they use that wristband, it can predict diabetic neuropathy, early stages of diabetic neuropathy. It's not. So you're preventing at least 1 in 5 don't know that they have diabetes. So when the diabetic neuropathy settles in, just even a simple indication, you can prevent. They will know. Oh my God, I got the diabetes. I need to run. Now it can save $4,500 per person. That simple device, because nobody wants to check the glucose. Nobody wants to do that. But they will work on the computer every day without knowing them. All the Fitbits, all these wearables, all failed because nobody wants to wait. Nobody cares after a while. That's not fashion. But nobody wants to stop working on the computer. Then, Susan, you like your friend Beth. This EMG, surface EMG, can recognize vitamin D deficiency years in advance. Vitamin B complex, the amplitudes of the EMG waves can tell us the vitamin D deficiency and B12, B complex deficiencies. Amazing. This is what it does. So it's a very new technology. Of course, it's a new technology. So what is that? So these microplastics, health hazard for the country is a 250, is going to the heart. Most of the people think coronary heart disease is mostly increased because of the microplastics. There is a study done. The second one is a suspect autism, a suspect children's autism, children's Down syndrome. All those things could be caused by this plastic seeping into the water. It cost, the direct cost of this one is actually computed in the economics is a $250 billion per year. 1.22% of the GDP of American growth. In the worldwide, $1.5 trillion we spend on the keyboard and plastics. AED. So that if you take that money, AED in every village in the world, you can put it. You can save lives. I'm a fan of technology, but technology is, let me tell you, I want to tell you, there are heroes also. I tell you why we need AEDs. I forgot this point. I want to tell you about AEDs. Why? AEDs, I'm going to give you real stories and real heroes here. That Phillips County, Montana, has a 4,000 population spread across 5,000 square miles. Cardiologist, there is 90 miles away, Dr. Samar, 90 miles away. AEDs is almost zero. They recognize the JAMA, the study done on them is a survival rate if they have a cardiac arrest is zero. If you go to Appalachia, Kentucky, I used to place doctors in Appalachian Mountains. I have to go Highway 23 all the way from Greenville. I used to go to Kentucky. Then I used to go to Kentucky. So Bluefield, Bradshaw, West Virginia, Bluefield, Hazard, Kentucky. My cousin used to work in Martin, Kentucky. All these areas, Pikeville, rural areas, they have coal mines. They have black fungus things. I used to carry water because we used to eat in the church because there is no restaurant even in some places in America. There's no food. So we used to go there and then eat that place. That's the only place in the mountains. So Appalachian Mountains, Kentucky, the 45 to 70 miles, there's no doctor, cardiologist there. AED is very few. Survival rate, the computer rate is a 5% if they have a cardiac arrest. Why in this country, America first? There are heroes here, right here. I'm talking with, Susan Davis. I know her very well. She champions. I'm really proud of her in that she goes to saves people and talk about the AED and trains them. It's a very, very American thing to do. It's saving lives. Dr. Samar, she is taking to the veterans, go through a lot of these hardships, and then they have this stress, PTSD, and all the other stress, preventing cardiac diseases. So we have to really, not this $500 billion on this data center. We need to do those kind of things. We can uplift the world. And thank you for watching. Those 17 equations in physics give you entire nature of the world, the nature of it works. So I wrote, the future of medicine will not be written by those who makes those noise about technology, but by those who return to the silent truths of physics and physiology, medicine, physicians and healthcare professionals and policymakers. Rokhanna is, I hope he's listening. He's on my podcast. He's not on the podcast. I want him to come back. People like Rokhanna and all those people, presidents and a lot of even the Trump administration, healthcare people, must not abandon science. It is our only path forward. Yeah, thank you for watching. Let me bring back my friends back to the stage. What do you think, Doctor? What do you think of all?
Ramana, that's a really interesting gadget, and sorry, may not be for healthcare reasons so much, but I'm a terrible typer, so I'm going to try that out to see if it's any good to begin
I
with.
want them on both arms. I'm going to get them on both arms, and for sure, I'm not a very good typer either. Very interesting, and Ramana, and thank you so much for all the kind words and the thoughts, and including AEDs. I really appreciate that you sprinkled that throughout your presentation this evening. Thank you.
Yeah. Dr. Samar, yeah, my job is to just both ways, because I'm in the middle of that technology and medicine kind of a guy. I'm in the middle of that. Very few people want to talk about those two together. But I want to ask, you're one of those people. You have to use technology for the imaging. Now let us talk about this new imaging. Is nuclear. Nuclear cardiology is functional medicine, right? You know the functions of the heart, wall motion, and all those things you study. But it is a huge, and the isotopes are challenging. So is there any evolution coming in the nuclear cardiology, or what kind of things it does better for you? And is it still powerful tool?
Yeah, it certainly is. And when it comes to stress tests, when we think about stress tests and think about nuclear medicine stress tests, what we're actually thinking about is the SPECT stress test, the cardiolite stress test that we're all familiar with, are all done on our SPECT scanners with our technetium isotopes, and they don't have very good sensitivity and specificity. But if you do those stress tests on a PET scanner with PET tracers, they have much better sensitivity, specificity. The radiation dose is lower with the PET tracers, and they do something. The PET tracers and the PET scanners can do something that the SPECT cannot, which is actually quantify myocardial blood flow. So when you do a stress test with PET, it can actually tell you how much blood flow is going to the different parts of the heart, which is very valuable information. So, PET is a very good modality of stress testing. The problem, as you rightly mentioned, Ramana, is the fact that it's not so much the PET scanner. Almost even every community hospital these days has a PET scanner for oncological indications. That same scanner that you would use for a PET stress test. The rate limiting step has been, to a large extent, the radio tracer, because the tracers that are needed for PET scanning, or for perfusion PET scanning, which we need for the stress test, needed to have a generator on site. And the cost of those generators was anywhere from $30,000 to $40,000 a month, which is cost prohibitive for most community hospitals.
I want to correct that. It's not it's not the electrical generation. You're talking about cyclotron, the radioisotope generator, right? Yeah.
The generator for the radioisotope.
Okay.
Yes.
That's
The generator for the
cyclotron. We call it
radioisotope.
cyclotron. Physics people. We are physics nerds. We call it cyclotron.
Yeah. That has to be on site.
Yeah.
So, and that's a huge expense, which does not make sense for a lot of centers. But now, just last year, the FDA approved a new a PET agent called flurpiridaz, which does not need the on-site generator. You can order it like order your cardiolite from your radio pharmacies as a unit dose. So if you have 2 patients for a stress test, you order 2 doses. If you have 10, you order 10. So that has really led to a resurgence in the interest of using PET scanning for stress testing again, which I think is great, because I think the field of nuclear cardiology, when it comes to stress testing, is really moving away from SPECT imaging and towards PET. So this new radio tracer is really going to move that forward in a big way.
Susan, this is your field now. When you inject like radio tracers, like contrast injections, so are there any problems with that? And is it particularly if you're injecting FDG or all these new things coming up, are there any studies done? You got to be very careful. Sometimes of allergic reactions and.
Oh, for sure. And it's, again, low frequency, high risk. But the interesting thing about non-invasive cardiology departments is first of all, their location. No one knows where they are. So if there is a problem in general, when there's a response from internal response teams, non-invasive cardiology tends to be kind of around the corner somewhere. No one really knows. We're conversely, like CT's always in proximity to the ER. MR, people aren't kind of sure where MR is. Echo, they're not too sure. Non-invasive cardiology, people are like, where is that? And then you have to look at the scope of practice of the people that are in that room. So yes, if they're giving any type of contrast media, anywhere contrast media is given, the opportunity from a reaction is 5 minutes or less. And so the response time, we do have, I should say it's kind of sort of job security. I do a lot of work in non-invasive cardiology and stress testing. Those rooms are small. They have a lot of equipment, making access tricky and difficult. So 0 to 5 minutes anaphylaxis to arrest is very possible. So I do a lot of work there. And the scope of practice is a varied, there's a varied amount of practitioners in there, sonographers, MAs, nurses, and we do a lot of work. And they respond well, but they do take a lot of practice.
Dr. Samar, as I said, that I act one on TV as a doctor, but I'm not a doctor. I want to ask, I want to get education. I used to sell, PET CT scan, nuclear tele machines. One of them is the isotopes are rubidium and the FDG. I don't know the difference, where they use it, what they use it for. The new one you're talking about, the new one. What are these uses? Where do you use it? What purposes they use it?
Yeah, sure. So when it comes to the PET tracers, I think we can think of them broadly in 2 categories. We can think of our perfusion tracers, and then we can think of the metabolism tracers. So the ones that people are mostly familiar with are the ones that are used in oncology, which is the FDG tracers, which are based on FDG, which has glucose molecule in it. And why do we use that? Because glucose is a source of energy for almost all cells, also for the myocardial cells. So yes, we use FDG tracers in cardiac imaging as well, but the indication for FDG tracers is much narrower. So we use it if we want to find out viability. So somebody has already had a big heart attack and we want to see that, is there any viable myocardium in that big area of scar? Is there any utility in, opening up that blocked artery that is supplying that?
Is it the muscle is weakening? Is a part of muscle is dead? That's what you're looking for viability means?
Correct. That in that area of myocardial infarction, are there still myocardial cells that are alive?
Okay.
And to do that, we'll use the FDG tracer. The other indication we use FDG for is actually for inflammation in the heart. So if we suspect someone has endocarditis, so an infection of a prosthetic heart valve, we will use FDG PET to be able to pick up that infection, which is very difficult to pick up on echocardiography sometimes. We use PET for other inflammatory conditions, FDG PET, sarcoid. If we suspect somebody has cardiac sarcoid, FDG is the tracer to use for that. So yes, we use FDG, but that's mainly for either viability or inflammatory imaging. You can club them in one bucket. And then the other tracers, which you was talking about, rubidium or N13 ammonia, or this new tracer that's come out, flupyridaz, they belong to the perfusion class of PET tracers. So we use them to look at myocardial perfusion, because these are tracers that are taken up by the myocardium proportional to the blood flow to the myocardium. Those are the perfusion traces, and then the other ones are the metabolism traces.
The perfusion, the volume of the blood going back, and all those all those things you can measure, right? In the
Yes, the volume of the blood going to the myocardium.
amazing. So I think the cardiology is moving to the. I think we are. Do you know that anything about the little bit of maybe it's out of your field, but I'm going to ask you transplants, heart transplants. You think it's going to be the future? We are going to take a pig heart and then put inside in the
They can 3D print a heart, Romana. We can 3D print a heart these days. I mean,
you want to print the- you want to print a
Now,
heart,
you're
you know.
absolutely right. That is one place that is, we really need some serious innovation in that area, because, as you know, the hearts are so difficult to come by. Any organ, for that matter, is so hard to come by for a transplant. The transplant lists keep getting longer and longer. Yes, there have been, you probably may have also read in the news about that patient surviving for several days when they did that, when they did that. I think it was a bovine heart or something that they transplanted in them, but of course it was, a limited survival. But and then they, the total artificial hearts and so on. But again, they all have their limitations at this point in time, and it's nothing is as good as a true heart transplant. So I think we're still a long ways away from seeing something really dramatic in that field. Or I have not heard of anything that is really ready for prime time that will change how we do heart transplants at this point.
Dr. Samar.
Dr. Samar.
Yeah, go ahead, Susan. Go ahead.
Well, I'm just all this talk about innovation and your expertise in cardiology is so valuable. I was wondering what you thought about. There's so many clinicians with your expertise and many other specialties that are leaving the walls of hospitals and clinics and heading out into the entrepreneurial and innovation world. I know you recently got your MBA in those very same areas, and I was very fortunate to meet you at Health this year. I was wondering, what was your take on how did you feel as a clinician with your expertise in that arena? And did you meet a lot of other clinicians? Do you think there is a wave of this happening? And where do you think we're going with that type of movement and transition in healthcare?
You're absolutely right, Susan. There are more and more clinicians who are entering this realm of entrepreneurship or innovation, whatever you want to call it. I think there were 200 plus clinicians at HLTH this year. And I think, and that number has been steadily increasing over the years, I'm told. It was my first time at that conference, but we are seeing more and more clinicians actively taking a part in whether it's industry, whether it's starting off their own startups or businesses or whatever. But you're definitely seeing a lot of clinicians sort of want to club their clinic, may not necessarily leave clinical practice entirely, but maybe club it with something else that allows them that creative freedom, or allows them to do something beyond the very regimented kind of medical practice that we tend to have at this point in time. So I think it's more for the freedom of creativity and to be able to do something more meaningful than. And taking care of patients, don't get me wrong, it's not like it's not meaningful. It's just the way
with the scale. It's the scale with your expertise coming in early with these technologies. It's your expertise that will help some of these massive innovations at scale. If you guys don't come out of the hospital walls, then you can't help us out here, and that costs money and takes time. So you coming in and others like you into these amazing tech companies early really can serve their world in a grander, I wouldn't say a grander fashion. In addition to our patient care, I think you can affect millions and millions more lives.
You're absolutely right on that. And I think clinicians stepping into roles like this and stepping into, these into companies that are in the healthcare field, I think is only going to take patient care forward. I think we really need to change that mindset of, looking at industry affiliations and people who step out of traditional healthcare with skepticism that, what are they doing? Patient care was supposed to be their calling, and this is some kind of, they're sort of doing something that they were not intended to do. I think we really need to move out of thinking that way. And that thinking is changing. It may be changing slower than we would like it to, but it most certainly is changing. And I think it would be great if it changed at an institutional level, where maybe we had institutions that allowed for this simultaneously, where you could be a clinician and, pursue something else that you're interested in at the same time. I think it would help to expand the field even further.
Dr. Samar, I think the physicians learning technology and other things are much easier than a technologist learning entire medicine. I can tell you. You thank you so much. You educated us in the beautiful presence you have, and then you really gave a very value to the MedBricks webcast. It's truly an honor and a privilege to have you on the podcast. Thank you so much. Thank you, Susan,
very
joining
much
from Cincinnati cold weather. And then tomorrow we have you must watch the great guest, there's a kid, 11-year-old kid, he spoke with us, Sanjay Gupta in CNN. It just blew my mind, so what it shows that it shows that our minds are limited by our own thoughts. You can expand our minds to so much potential there. Doesn't matter. Actually, what you're proving is that we all can expand our brains in much more bigger and understanding things much more easier. Thank you so much, Dr. Samara. I'm truly honored to have you. Thank you so much. It's a fun talking with you. And Susan, thank you for joining with all the cold and all the stressful day. Thank you all. Good night.
Thank
Susan,
you, Dr. Samar.
thank you so much for having me. I had a lot of fun. Thank you.
Thank you so much. And thank you for taking care of our veterans. Good night.
Thank you.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.